Hello colleagues, I'm Subodh Verma. I'm a professor at the University of Toronto and a cardiac surgeon, and along with Shubh, it's really my great pleasure to welcome you to yet another edition of Legends of the Heart. As you know, Legends of the Heart was a series that has been put together to really showcase truly transformative individuals, people who have changed the landscape of cardiovascular medicine. Today we're delighted to tell you the story of Professor Paul Ridker. I've known Paul for, believe it or not, a quarter of a century as a friend and as a colleague, and I've really benefited tremendous from his mentorship and from his guidance. Paul has not only been one of the most instrumental architects, if I may, in cardiovascular prevention, but he's also been a tremendous mentor to many cardiologists and trainees over the last several years. Almost 40 years of sort of one thought, and that is inflammation. Understanding inflammation from the bench to the bedside. He's really the father of inflammation and atherosclerosis. Paul's contributions to the science of inflammation, understanding how it plays a role in the pathophysiology of atherosclerosis, to now understanding inflammation as a therapeutic target, has really ushered in an entire new paradigm in the field of cardiovascular medicine. Personally, I have really benefited from your friendship, from your kindness. There's very few people who have achieved as much as you have and have had such a major impact that also have sort of this generosity of spirit. And it is with great honor and privilege that Shubh and I welcome you to the Legends of the Heart. And thanks for everything that you've done for the field.
Well, Subodh, it's an absolute pleasure to be here, but let me alter one thing you said right up front. None of this, do any of this in isolation. This notion about inflammation, heart disease, it requires people with basic science approaches, people with physiology approaches, people with epidemiologic and clinical trial approaches. There's a wonderful group of people internationally who've all contributed to this field. But it's very kind of you to be here, and it's delighted, Shubh, to meet you as well.
Pleasure.
You represent, I think, the future of this field.
That's right. So Paul, I think the viewers want to know what got you into the field about 4 decades ago. Why inflammation? The lessons you've learned, you know, looking back, things you would do differently. We want to hear it all.
Well, there's many different places I could start. One is the most clinically relevant, which maybe is the most important one. When I was an intern and resident, and then ultimately a fellow at the Brigham and Women's Hospital in Boston, one of the things I learned very quickly, that we all learn, is that the textbook's not quite right. The textbook is what we have as our prevailing current myth. And the textbook changes every couple of years as it's rewritten. And the prevailing myth at the time was that our risk factors predicted heart disease. But rounding in the coronary care unit, it was quite clear that wasn't the case. It seemed to me that somewhere between 30% and half of all the heart attacks and strokes we saw coming in, and you and I are old enough to know it was all STEMIs back then.
That's true.
They didn't have hypertension, hyperlipidemia, diabetes, or they weren't necessarily heavy smokers. So we had lots of people coming in where we could not explain why this individual suddenly ended up with a catastrophic event. It just didn't make a lot of sense. That's part A, was just the sort of, the book is wrong, how do we figure this out?
What's the missing piece?
Yeah. Part B is a little bit of luck. I had a background from earlier in my life at the bench in innate and acquired immunity. I had spent some time at the NIH doing immunologic research. Mostly was actually on the gastrointestinal tract, not on the heart. It was way before I knew I was going to be a cardiologist. But that gave me a literacy on how to read the immunology literature. And the third piece of boat is one that may surprise you, which is that I also, as you think you know, I spent a year in sub-Saharan Africa. I thought I was going to be an infectious disease doc. My first love in medicine was infectious disease.
Yeah.
And that interest in recognizing that in that part of the world, we had very little heart disease, despite incredible amounts of inflammation. But when people migrated to the cities, they suddenly had the same problems that we had in our Western culture. I think that sort of look at population biology from that perspective is also there. The other thing I'll say to Shubh is that the other trick to this whole business is finding out what you're actually good at. There's one thing to have some good ideas. That's usually good. That's usually useful.
That's a good first step, yeah.
But the other is to recognize, what am I good at? I could never be a cardiac surgeon. I think that's a skill. It's a physical skill that you have to do along with the mental abilities to do that. But I'm good at math. I'm good at thinking about global population epidemiologic issues. It would be very hard for me to have been a bench scientist. Now, I love reading Cell and Nature, but writing for those journals requires a different kind of perspective. And my own skill set was very much epidemiologic, population biology, and trying to figure out how do we actually change the practice of medicine.
Yeah, and if I may interject, how did you know that that's, I guess, those were your skill sets? So as a trainee, as I'm going through medical school now, sometimes it's hard to navigate that kind of realm and knowing, like, you know, what I'm good at versus not. So I guess going through your career, how did you exactly figure that out?
Sure, it's a really important question, and it really boils down to looking in the mirror one day and saying, here I am, I've trained, I wear this stethoscope, and outside of my clinical abilities, where is my research skill coming from? For some people, it's because they're superb in terms of that bench science approach to things. Others have very different skill sets. Some become population biologists, some become outcomes researchers. All these things yield very valuable information, but you focus on a very different part of the problem. So I think you just figure it out on your own about what works. But there's a corollary to that. Science is not a linear process. I'm not even sure it's a random process sometimes.
Right?
But it does get from A to B to Z slowly, with a lot of detours along the way that most successful people don't talk about. I think people talk about, well, I had this idea, it led to that idea, led to that idea. The reality is, this idea didn't work, but I had the ability to change course. Subodh and I are old enough, we have some colleagues who don't change course. That's also a problem, because at some point you have to realize, I had this idea. Let me give you a personal example. We didn't think inflammation was the first way this was going to happen. We thought it was thrombosis. Wrote papers in top journals about TPA and Pi1 and thrombotic factors. But it became apparent that this wasn't going to change practice, and that ultimately this wasn't the real discriminant between why some people didn't have these outcomes. And the ability to say, well, this is interesting. We're getting some attention for this work, but always being your own biggest critic, was it having impact? And the answer was no. And we had to look elsewhere.
You know, I think, Paul, I admire many things about you, but one in particular is sort of the laser focus you've had on inflammation, right? You know, on one area. And you see scientists that have been successful that sometimes sort of, you know, oftentimes will sort of change trajectories, you know, change their path. And we want to hear more about that, you know, you've sort of really stood by that thesis for a long time. You know, even when they were, like, you know, today people talk about inflammation and atherosclerosis, so it's a given, you know, we know it's, but, you know, you and I have seen and lived through the evolution of the field, where they were more naysayers at times around the biology than there were people supporting.
Yeah, that's absolutely true. Although in reality, I think if you're a good scientist, you are your own biggest critic of your work. So it's very rare to be hit with a question you didn't actually think through 30 or 40 times over already. So even though there are slings and arrows that come, usually the answers you've already run through in your head about them. But I will say something a little different. I think there's an element to this of sort of recognizing something really mattered. And again, there's a luck piece of this. The very first major paper in this arena that we would publish changed a lot of paradigms right up front. Prior to our paper, Attilio Masri in Rome and his colleagues had shown that inflammation comes after acute ischemia. That was not a big surprise. We know that ischemia is an insult. But it begged the question of what's causal or what's casual. How do you sort that out?
Right.
My scientific mentor at the time, a guy named Charlie Hennekins, had run the Physician's Health Study, a trial of aspirin to prevent heart disease. Samples had been biobanked, so we could ask the question in initially healthy individuals, was this inflammation present or not? Yes, it was. And did it predict the future vascular events? Yes, it did. And the lucky thing was, it was an anti-inflammatory intervention. It was an antiplatelet drug, aspirin, that has anti-inflammatory effects, and we got this big effect modification. And the insight was to say, wow, this is a biologic process that precedes, now we know by 30 or 40 years, the onset of a future vascular event. That puts it in the same realm as LDL cholesterol and blood pressure as a potentially modifiable risk marker or risk factor. And then the second lucky thing was, at the time, I lived across the street from Mark Pfeffer.
Oh, yeah.
Mark Pfeffer had just done the CARE trial with Dr. Braunwald and Frank Sachs, and they had shown that, it was pravastatin back then in terms of secondary prevention.
This is now like 2000.
No, this is 1998, 1999.
Yeah, exactly.
And there were, again, things that didn't make sense about statins. The drugs seemed to be more effective than they should have if all they're doing is lowering cholesterol. Because why are they having effects so quickly? Anyway, long and short, we would measure a number of inflammatory biomarkers. CRP became the standard. And we're able to show very early on that statins were twofers, that predominantly lowered cholesterol, but also had these anti-inflammatory effects, that you lowered CRP, and the rest of it just kind of exploded.
Fast forward to the sort of the CIRT and Cantos days, right? Tell us those stories.
Well, we have to stop along the way at Jupiter for 2 seconds.
No, for sure, yeah.
Because Jupiter was a really important step along the way to getting to Cantos and ultimately where we are today with the IL-6 trials. Yeah. Because we never could have gotten there without it. And that's important to understand.
I remember when it was presented.
You were part of it with us.
Of course. I remember getting a phone call from you saying, we've stopped the trial early, or, the DSMB has asked for the trial to be stopped early. And it was stopped, about 2 years in advance, wasn't it? Or
it had less than 2 years of total follow-up. But the point was it had a reduction in all-cause mortality, as well as this nearly 50% reduction in events, which by any standard today, we never see things that large anymore.
That's right.
But the idea was if we targeted a lipid-lowering, inflammation-inhibiting drug, statins, not to people with a high level of LDL, but to low levels of LDL, in primary prevention, but in elevated CRP, we got this phenomenal benefit. Now, that changed guidelines worldwide. Very proud of that study. But it didn't answer the fundamental question about whether or not targeted anti-inflammatory therapy could lower risk, because it was a lipid-lowering drug that we exploited its anti-inflammatory properties.
Yeah.
So that's really, but without that, there would be no Cantos. So in about 2010-ish, Peter Libby and I would get on a plane to Basel, and Peter was great at opening doors along the way. And we said to the folks in Basel, which is Novartis' headquarters, look, you have this IL-1 inhibitor, canakinumab, that's being used for a variety of orphan diseases that are rare but very important to the kids who have these overexpression IL-1 syndromes. And we'd like to do a 10,000 patient hard outcome trial of that orphan drug to actually test the fundamental hypothesis. Because a monoclonal antibody targeting IL-1 hit a lot of right buttons. Incredibly precise. We know exactly what it's doing.
Right.
If it knocks out IL-1 beta, it's also going to knock out downstream interleukin-6, where we're heading with our new trials, and eventually gets CRP to come down. And we knew it was relatively safe. And to their enormous credit, Novartis said, sure, let's do this 10,000 patient experiment. And in 2017, and again, you're a part of that, when we were able to present these data, the fundamental issue was, we got a 15 to 17% reduction in MACE and MACE plus without changing ApoB, without changing LDL, by targeting this fundamental pathway of innate immunity.
I think it was a new day for the field.
And the extraordinary thing was that's the same 15 to 70% risk reduction that was reported the same year in all the PCSK9 trials.
That's correct, I remember.
But that's due to getting LDL down extremely low. And today, I think our goal is to use both of these types of therapeutics. So it's kind of an exciting time.
No, I know, Shubh, you're dying to ask a question, but I read a paper of yours actually this week as I was, getting ready for rounds with the youngsters about sort of triple targeting. This is your European Heart Journal paper. I think it's from last year or so. And this is sort of addressing the three different axes, right? The LDL axis, the LPA axis, and the CRP axis. Tell us about that, and then I'll hand it over to Shubh.
Sure.
Because I thought that was an incredibly easy paper conceptually to translate, to say, forget about scores, focus on three pathways, you know?
Well, this is the advantage of being a population biologist, I think, is that you can think outside the box and say, look, we use these scores, which have changed a little bit over the last 45 years, but not in any way that's really substantial. And they've never worked all that well anyway. And why are we still dealing with non-modifiable risk factors? So the epidemiologic question there was, if we simply measured the three things we think matter, LDL, inflammation with CRP, and Lp(a) for those people who have it, on the assumption that the LPA trials might be effective, which I hope they are,
Right.
that risk score based on those three things is almost as good as the entire risk score, but it's focusing on modifiable factors. Now remember, our ongoing IL-6 trials, again, you're our Canadian lead for these, they're not done yet. We may know by the end of this year whether or not the first of those, the Zeus trial, is effective or not. And we need multiple proofs. But for inflammation, we have Cantos, which is the proof of principle. We have the Colcott and Lodoco 2 trials for colchicine, which are very effective.
And they've led to guideline changes.
And they led to guideline changes. And if Zeus is also positive, and I really hope it will be, but I don't know, neither is the company, we're all blind.
Right.
Then I think we'll have enough evidence to really flip the switch on this whole thing and get these drugs to patients. LPA has to go through the same process. No doubt it's a risk marker for a small number of people, but for the families that have it, it's a real issue.
Yeah.
And we need multiple trials saying it's not just we can lower it, we can lower the event rates. But if all those things happen,
We've got the tools.
atherosclerosis is going to be a very different thing very soon.
Sure.
Yeah. I mean, everything you've just talked about, it just shows that the work that you've done over these past few decades, Dr. Ridker, it's really changed the field of cardiovascular prevention. But what do you think, is there still something that's missing in terms of what you've been doing? And if so, like, what do you think are the next steps in this?
So Shubh, one of the interesting issues in the way research works is it takes a long time to get from an idea to practice. And I'm not even talking about the long time it takes from get from the idea to the guidelines, but to get from the guidelines to actually changing practice. I think one of my, I don't have many regrets actually, but I have not focused that much on the on the operational end of it. I think I made the assumption that if you showed overwhelming biology,
The process
overwhelming
takes care of it.
evidence, overwhelming clinical trial evidence, that it would take care of itself.
It's not true.
It's not really true.
Yeah.
But again, I think we talk about our own skill sets. That's someone else's skill set. I mean, communication, education, yeah, I can do that. But sitting in a room with lots of people trying to come to consensus, not my strength. I'd rather be on the tennis court doing something else probably. And that's part of the problem. So I think someone else has to step in and say, look, we need to really put this into practice. And it's not just a guideline issue. Then it's an issue of payers. It's an issue of changing practice. It's a culture change. And these are things that, you know, are many other steps along the way. And it's hard to do.
So, you know, last 5 minutes, 2 minutes. Friends, family, other things you value. We all know, you know, your scholarship. We all know your impact. You want to hear, you know, more about that.
Wow. So one of the biggest thrills of my life is watching my kids succeed. It's just so fun. As you know, I have both my children are writers. One is a novelist. One writes for television and for the movies. And it's a blast for me when I see them do stuff and I get to realize, where did these little geniuses come from? Yeah. It's pretty great. I've been blessed to have a wife who I still adore and, you know, want to spend more time with. And that's been great. I also have a lot of connections in life. As you know, my brother-in-law, Harlan Crummels, is also a cardiologist. He's the editor of Jack. And so we have a whole cardiology thing going on inside the family there. But I think, you know, at the end of the day, it's family that matters. It's the way you live your life that matters. It's sort of a sense that you've made a contribution, whether it's in the clinic for your own patient sitting in front of you, or maybe some broader group of people who you don't actually know. But I love being an academic cardiologist. would do the entire career over again tomorrow. If I was given the option, I wouldn't change many things about it. I feel very blessed.
Wow, amazing. Shubh?
And I guess for those of us who are earlier in our training, such as myself, your story is really a powerful example of, seeing something that the field hadn't even seen, staying with it for long enough to even change practice. And so what advice would you have for the next generation of trainees, including myself, in terms of navigating like an issue or a problem and devoting an entire career to it, and then also sticking to that idea even when times or the path is uncertain?
Shubh, I would say two things. First, your generation is inheriting a very different world than we did. And I don't mean just medically, but sociologically, politically, a lot of other things are complicated. And we're seeing AI just take over our world.
Oh my goodness.
Some ways are going to be good, some ways are going to be not so good.
Yeah.
And I am blessed that I didn't have to deal with social media at all in my life. That being said, young people are just as smart, just as aggressive, just as thoughtful. So I would say identify a problem that interests you. Mm-hmm. Doesn't have to be a big problem. It may be a problem that's only for a small number of people, but for them it's a crucial issue. And then I think the other thing is to sort of get a thick skin. I think Subodh already raised it earlier. I don't want to go through it in a public kind of forum, but if I had listened to the critics along the way, we never would have been where we are.
Correct. Absolutely.
I think you have to sort of say, I think I know what we're doing. Mm-hmm. And it's part of being your greatest critic is your own self anyway. And let some of those other issues, which do bother us, they do, let them go and just stick to the bigger idea of, wait, but this is the signal, this is the noise. How do I get from A to B to C? Some detours along the way. That's how science works.
Right. Well, we've had a wonderful conversation with you, Paul. I just wanted to say a couple of words as we close, and that is, when I think of you, the first five or six words that come to my mind are not science, they're not inflammation. It's kindness, it's compassion, it's generosity of spirit. I've always, I could text you and I get a response back. You say, give me a call, Subodh, happy to chat with you. You've always made time for me and my family. Those are some of the traits that I think nobody knows, and you can't measure those in scientists. Of course, we know your scholarship, we know your impact, and we thank you for that. The entire field thanks you for that. But, you're just you're a very unique human being in that you've given a lot to people, and we thank you as a community of cardiovascular specialists and physicians at large for your major contributions. And good luck with Zeus. I hope it's a positive.
Well, first of all, Subodh, you're very kind, you're very flattering, but Shubh's the most important person sitting here.
That is true.
Because the reality is, you and I are going to need good doctors, and you are going to need new research and new medicines down the road. So it's really in your hands that we pass this ball.
Well, thank you for being with us today, Dr. Ridker.
Thank you, Paul. That was wonderful.